We're going to talk about the cardiac action potential to the right here, and then just briefly go through. If I could just take a quick 60 seconds of your time, I wanted to introduce our newest whiteboard medicine emergency and critical care community, and that is our Patreon community. Here we post emergency and critical care medicine medical education topics every other day. We focus on landmark trials, new trials, clinical pearls, bedside tips and tricks, and much more. Everything emergency and critical care. We also upload study guides for each video. We have practice tests, and our newest addition is going to be mini courses that kind of lay out video study guides, practice questions into an easily digestible form that we hope is very applicable and helpful to the bedside. Our goal is to try to get even 1% of our YouTube community to join our Patreon community. It would be incredibly helpful in allowing us to spend more time creating content and elevating our current content. We appreciate you all, and we hope to see many of you there. Classes of antiarrhythmic drugs 1, 2, 3, and 4. Then with each subsequent video, we'll dive into class 1 drugs, class 2 drugs, class 3 drugs, and class 4 drugs, and kind of go in more detail within each class. So to understand antiarrhythmic drugs, it's important to understand the cardiac action potential. So what we're going to first do is talk about the different classes, and then we'll talk about how they relate to the action potential over here. So the first class of antiarrhythmic drugs is going to be known as class, I already spelled class wrong, good for me. Class 1. And this class are sodium channel blockers. Alright, and we'll get into how this relates to the cardiac action potential to my right once we're done going through the classes. Class 2 is going to be beta blockers, which are, a little different mechanistically. They don't use as much with this cardiac action potential as the other classes. Class 3 is going to be potassium channel blockers. For consistency's sake here, we will do a capital C. And then class 4 is known as calcium channel blockers. All right. So, what are these and how do they relate? Oh, let me mute my computer there. Relate to the cardiac action potential. Well, the cardiac action potential over here does vary depending on what cell you're looking at. We're going to look at the cardiac action potential of a ventricular cell, so not a pacemaking cell like the SA node or AV node, but just a myocardial ventricular cell. So these cells often sit at about negative 90 millivolts. And that's what we'll say here. And this is during a phase, right? It's broken up into phases. This is phase 4. So this is after you've had an action potential, you've repolarized, you're at the end of diastole, and you're at your kind of negative 90 millivolts. All right? When that occurs, the pacemaker cells will start with another action potential, and that travels through gap junctions to the neighboring myocardial cells all the way down to the ventricle. And what that prompts is phase 0. Okay? And that's kind of this uptick. In phase 0, you start to have a huge shift in potassium. So, I apologize, in sodium. So what you have is a big influx of sodium. All those sodium channels open up and sodium influxes into the cell. That leads to this negative membrane polarization becoming more positive. And when you reach what's called the threshold, that is when the depolarization takes off. The threshold principle is kind of a principle we call the all or none principle. So what it means is that you can't just kind of get a half depolarization. If you don't get enough sodium to reach this threshold, to make it positive enough to reach this threshold, then you'll get no action potential. If you get enough sodium influx to reach this threshold, then you will get the full action potential. You get all of the action potential or none of it. There's no in between. All right, and that's phase 0. As the cell is becoming more and more positive, because sodium, right, is a positively charged ion, you start to then get the next phase, and that's going to be phase 1. Okay? And what happens with phase 1 is that you actually start to get potassium channels opening, and potassium starts flowing out of the cell. So this is going to be intracellular, right? Increased sodium and now decreased potassium. Potassium is also positively charged, so as that potassium flows out of the cell, this depolarization, right, will start to move more towards the negative and less positive. Then why do we get kind of this brief plateau, which is known as phase 2? Well, you actually then get L-type calcium channels that open and start increasing calcium going into the cell. So what we have so far is the sodium was traveling into the cell through phase 0, then potassium channels opened, potassium started flowing out of the cell, sodium channels here start to close, so close sodium, and you're starting to get kind of that less positive, more towards the negative, but then you get the plateau as calcium channels open up and you start to get the influx, increased air of calcium into the cell. All right, and that occurs until about phase 3. At this point, calcium channels close and you're just getting that efflux of potassium until you return to phase 4, right? And now you're back here and it cycles, back through. So understanding this helps us understand how these antiarrhythmic drugs work. For instance, class 1 antiarrhythmic drugs, sodium channel blockers, there's actually subclasses, class 1A, 1B, 1C, but these are things like procainamide, lidocaine, flecainide. Check out, when we come out with our class 1 video to go into more detail. But what these do is they block these sodium channels in phase 0. By doing so, they decrease the slope of phase 0 so that the action potential is slowed down. So you can picture it like this, right? They're going to decrease the slope of phase 0, right? The slope is here, to slow down that action potential, and it takes then a longer time to depolarize. And that can assist with arrhythmias. By slowing down that action potential, you get less, re-entry and things like that. All right. Beta blockers are a little different. Beta blockers stimulate kind of vagal tone in the pacemaker cells to slow down the heart rate. So beta blockers are different, and we'll go into that when we make our class 2 video. Class 3 though, beta blocker examples, they're things that we all know about: carvedilol, labetalol, sotalol, atenolol, metoprolol, etc., etc. Class 3 are potassium channel blockers, and let's think about how potassium channel blockers might work. So we have the potassium channels opening up and sodium is flowing out of the cell, decreasing intracellular, potassium is flowing out of the cell, decreasing intracellular potassium levels. At the same time, the sodium channels have closed, so you're no longer getting that sodium gradient that is changing, and you start to then, kind of move towards repolarization. That positive millivolts of the ventricular myocardial cell starts to become less positive and move towards negative. Well, class 3 are potassium blockers. These are things, and there's some mixed pathways too, but things like amiodarone, dofetilide, ibutylide, etc., etc. And these are going to block potassium channels. And what that is going to do, it's going to increase the time that the cell takes to repolarize. And while this cell is repolarizing, it cannot get another action potential. It's refractory. So it prolongs that kind of QT. So essentially what we might look like here is, you're going to get your normal uptick, normal downtick, but then this is going to be longer, right? Because you're getting less potassium coming out of the cell. And during this time, you're not going to be able to get an additional action potential. It's refractory because it's still repolarizing. And as such, it will then, again, prevent reentry, prolong that QT interval, okay? And then class 4 are calcium channel blockers. These are, there can be both, we're not going to get into this in this discussion, but cardioselective, non-cardioselective. But essentially, if you block these L-type calcium channels, you will regulate the influx of calcium and then also regulate the current and the return to phase 4, so if you have less potassium or less calcium channels, you'll get that regulation of this phase 2 plateau, and that can be helpful for arrhythmias as well. Also known as beta blockers. So this class of drugs is a little, I don't want to say less confusing than the other classes, but it doesn't go into the cardiac action potential as we've been talking about with the other antiarrhythmics. This class of drugs actually binds to beta adrenoreceptors, and as such, they block norepinephrine and epinephrine, which are, sympathetic surge types of molecules. By doing so, they affect nodal conduction. So they, are less important for kind of myocytes and things, but they affect nodal conduction, right? SA node, AV node, and those other pacemaking cells, SA node, AV node, and other pacemaking cells. How does this work? Well, if we draw out a little heart here, I didn't plan to do this, so I apologize for my, spur-of-the-moment drawing. But we have, nodal tissue. We have an SA node up here, we have the AV node here, and the action potentials depolarize the atria. They then go from the SA node throughout the atria, and then they all converge into the AV node, where they go through, the bundle of His, and then into the Purkinje fibers, into the right and left bundles, and then they depolarize the ventricles through that. Well, on these nodes, we have beta 1 receptors and beta 2 receptors. All right? Beta 1 receptors activation increases contractility, also known as, contractility, also known as inotropy, and also increases heart rate, also known as chronotropy. Beta 2 receptors have more action on vascular smooth muscle, and activation of them, smooth muscle will abbreviate SMM, activation of them, so increasing them, causes vasodilation of smooth muscles. This is where we get into non-selective and selective beta blockers. Excuse me. So, beta blockers affect both beta 1 and beta 2 receptors, but different beta blockers affect them differently, right? There are selective beta blockers. I'm going to scroll down a little bit. And these selective beta blockers, most of them, I remember when I was in med school, I'm not sure if they're still using this, they use the pneumonic beam, because you're beaming the heart with these selective beta blockers. Selective means that they are much more selective for beta 1 receptors on the heart, right? Which are responsible for contractility and chronotropy, or heart rate, and, inotropy and chronotropy are heart rate and contractility. And beam stands for bisoprolol, esmolol, atenolol, acebutolol, butalol, and metoprolol. There is also one that I personally have never used called bituxolol that is selective as well. When we say selective, what we mean is that they, have very little beta 2 action, and thus have very little action against, let me rephrase that, very little beta 2 action, and as such they don't tend to affect blood vessels, or vasodilation, which is a beta 2 property. This is in contrast to non-selective, which are going to have, as we talked about, both beta 1 plus beta 2 activity. And non-selective are, the ones that aren't selective. There's going to be things like carvedilol, labetalol, I think it's alol. In addition to that, nadalol, propranolol. I'll just list out a few more: sotalol, timolol. So these are non-selective. And what that means is that they can also lead to mild vasodilation. Now, don't be mistaken. The selective beta blockers can still affect blood pressure, right? Because it's decreasing contractility and heart rate, which can affect the blood pressure, especially contractility. But they don't have a direct effect on the beta 2 receptors in the vascular smooth muscle like the non-selective beta blockers do. All right? When we talk about what they're used for, we primarily think about them for a few things. One, after acute coronary syndrome or myocardial infarction, they are started because they decrease myocardial oxygen demand, right, by decreasing heart rate and contractility. We also use them for tachydysrhythmias, right? They're an antiarrhythmic. This might not be the best spelling. Dysrhythmias, because they decrease automaticity by decreasing that release of epinephrine and norepinephrine and stimulating that inhibiting that beta 1 receptor on the nodal tissues. All right. They're used in heart failure as well because they prevent myocardial remodeling. And then, although they're not your first, or second, or really third line drug, sometimes they're started for hypertension, specifically the non-selective, since they also can affect peripheral blood vessels. So class 3 antiarrhythmic drugs are commonly referred to as potassium channel blockers. All right, so their primary mechanism, and many of them actually have multi-factorial mechanisms, are blocking the potassium channel. Excuse us, what does that mean? So the potassium channel is responsible for phase 3 repolarization, as well as kind of phase 1 and 2 as well. So this should look familiar for those of you who've been following kind of the series here of antiarrhythmic drugs. But we have phase 0, which is sodium coming in. Sodium is positively charged, which means that this initial negative, let's call it 90 millivolts, starts to become less negative and more positive. While this is happening, we get towards phase 1, where sodium or potassium, which is also positively charged, starts to flow out. That then brings the depolarization closer to, less positive, more negative. At the same time, sodium channels are starting to close. Phase 2 comes along, and calcium says, well, wait, let's kind of plateau for a little bit. Calcium starts flowing in. Eventually, calcium channels close, and then we just have potassium flowing out, which then leads to the rest of repolarization. Okay, so class 3 antiarrhythmic drugs, potassium channel blockers, by blocking potassium channels, all right, we are going to, I don't know why that went crazy. We're going to increase the time that this cardiac depolarization cell is repolarizing. You're going to prolong that, phase 2. And by doing such, you're going to prolong the QT interval. What does this mean? Well, if we look at an EKG, an electrocardiogram, we get the tracing, right? You start with a P wave, which is atrial depolarization, and then you get into the QRS, right? So you get QRS, and then you get your T wave, which is repolarization. So here you have a P wave, here you have a T wave, and then you have kind of the QRS. That's a widened QRS interval, but just ignore it for now, pretend it's tighter. So what we get here is a prolongation of the QT interval because you get prolonged repolarization, right? That this area here ends up being longer. So you repolarize for longer, so you get prolongation of QT interval. The reason this is efficacious is because you can't depolarize while you are repolarizing. So by prolonging the QT and prolonging repolarization, you decrease the ability to depolarize again quickly. So potassium channel blockers are great for re-entry tachycardias. What that means is that the abnormal action potential, the abnormal rhythm, is trying to depolarize the cells too quickly. So if you prolong repolarization, decrease the ability for that cell to depolarize again, this tachycardia can't re-enter quickly, and that's why it's great for re-entry tachycardias. All right, so that's the mechanism. Now let's talk about the different drugs. I set up a little table down here to do so because many of them are kind of multifactorial. So the first one's amiodarone. This is probably the most common one, and its therapeutic uses, primarily we see this for ventricular tachycardia, ventricular fibrillation you can give it, and then atrial fibrillation and atrial flutter. Right? Because all these are tachycardias where there's lots of reentry. The comments that we would say for amiodarone is that it has a very long half-life. So half-life T 1/2 is half-life. Actually from 25 to 60 days. So extremely long. It also has, believe it or not, class 1 antiarrhythmic, which is sodium channel blockade, class 2 antiarrhythmic, which is beta blockade, class 3, which we're talking about right now, which is potassium blockade, and then also class 4, which is calcium channel blockade. It has class 1, 2, 3, and 4 actions. So we talk about it as a class 3 potassium channel blocker, but it actually has actions for all of them. Because of this, it decreases it prolongs the decreases the velocity of the action potential, prolongs the refractory period, and is great for all those re-entry and tachydysrhythmias. Okay? There are some serious adverse effects that can happen. All right, AE adverse effects. These most commonly and most tested are things like pulmonary fibrosis in the long run. All right, it can cause hypothyroidism, but can also cause things like liver dysfunction in the short term, so you got to monitor those types of things. All right, next one is dronendarone. This is often used for AFib, A-flutter, so just those atrial tachydysrhythmias. It is structurally related to amiodarone, which I actually didn't know until I put together this discussion. So structurally, it's related to amiodarone. I'm just going to write related to amio. With that, though, it has a shorter half-life. So as we saw with amiodarone, the half-life was 25 to 60 days. The half-life of dronendarone is only 13 to 19 hours, which is still a fairly long half-life for a drug in general, but obviously much shorter than amiodarone. As related to amiodarone, it also has class 1, 2, 3, and 4 activity, right? So sodium channel, beta blocker, potassium channel, calcium channel, all right? And that's very similar to amiodarone as well. And then, just so you know, it is contraindicated, CI, contraindicated in decompensated heart failure. So decomp heart failure, you don't want to start it. Studies have shown worse outcomes in decompensated heart failure. And then the FDA essentially said that there's a warning for acute liver failure. All right, so there's an FDA warning that it can cause acute liver failure, which we'll do ALF for acute liver failure. All right, the last thing to note is that it's actually only approved for paroxysmal AFib, not permanent AFib. What they essentially say is that you want to start it in someone who is in sinus rhythm but intermittently flips into AFib. You don't want to give it to someone in permanent AFib. All right, beryllium. Beryllium is primarily used for ventricular tachydysrhythmias such as VTach and VFib. It's only available intravenously. It does have this odd thing where you get norepinephrine release initially, followed by norepinephrine inhibition. I do inhibition circle with a cross through it, so you get release of norepinephrine first, followed by inhibition, and this can actually lead to hypotension. So I personally have never used this medication, but you want to monitor for hypotension if you're going to give IV beryllium. All right, sotalol. You might recognize sotalol from our class 2 antiarrhythmic discussion as a non-selective. It also has class 3 actions. It can be used for ventricular tachycardia, as well as atrial fibrillation and atrial flutter. All right, and then just of note, as we talked about, it also has class 2, obviously beta blocker activity. So that's kind of the big comment there. All right, ibutylide. Ibutylide is primarily used for atrial tachydysrhythmias, AFib, A-flutter. It also is IV only, so you can't take it orally. It can cause arrhythmias, so it's kind of a, you got to be careful when you use it because it can treat atrial dysrhythmias, but it can cause arrhythmias. You essentially get this slow inward sodium activation, which can delay repolarization. So it has potassium channel effects, but it also has this slow sodium inward activator that also, just like if you blocked potassium channels, slows repolarization or repol. All right, and then last but not least, dofetilide. Dofetilide is primarily used for atrial dysrhythmias, AFib, A-flutter. It is a selective potassium blocker, so it doesn't have alternate class activity. It has been associated with, though, and again, this is just like ibutylide, associated with life-threatening dysrhythmias. So you can use it to treat atrial dysrhythmias, but it also can cause life-threatening arrhythmias, which, when you are inhibiting certain channels within the cardiac action potential, obviously that's something that can occur. So class 4 antiarrhythmic drugs, we'll get back into these depolarization action potential graphs here in a second, but calcium channel blockers essentially block L-type calcium channels. Ooh, I don't know why that got all fuzzy. L-type calcium channels. All right, what does that mean exactly? Well, these channels can be found actually on vascular smooth muscle SMM. They can be found on cardiac myocytes, and they actually can also be found on cardiac nodal tissue. So there's multiple areas in which these calcium channel blockers can work, all right? In terms of their, specific mechanism, it regulates the influx of calcium into these cells. All right, so the channels, the L-type channels, as you can imagine, regulate the influx of calcium into these various cells and thus cause changes to those cells. Specifically for the action potential, we need to kind of talk about the nodal tissue and the myocytes. So calcium channel blockers, with kind of this thought in mind, right, affect both cardiac myocytes as well as cardiac nodal tissue. And the action potential that you see with nodal tissue and myocytes are different. And I think it's worth discussing. So what we'll do here is we'll first talk about the nodal tissue. When the nodal tissue starts to depolarize, you get this sodium influx, and that's what you see here. So sodium goes in. After that, though, you actually get a calcium influx from those L-type calcium channels. All right, and this is calcium in, specifically L-type. Oop, let me mute my computer here. Then after that, you will get the efflux of potassium, so potassium out, leading back down to, the more negative sitting potential of the nodal tissue. Okay, so keep that in mind, and we'll come back to kind of that effect of blocking this calcium channel. Now we go to the myocyte. The myocyte is a little more complex. So you can think of it kind of as sodium is going in here. So sodium in. At the same time, though, there's some calcium going in as well. Here, you start to get potassium out. The sodium channels start to close, but you still are getting some calcium in for a period, and then that stops, and that is when repolarization finishes. So you start to get some calcium in, you still have calcium coming in, and then it stops. Potassium is going out, and potassium keeps going out, and that's repolarization, right? Because you start at negative, let's say about 90 millivolts, and you're starting to get less negative and more positive as sodium and calcium are flowing in, then potassium starts flowing out, and you start to get more negative again. Same thing here, you start negative and you're going more towards positive. These are L-type calcium channels as well. So in terms of one of the mechanisms of calcium channel blockade, you are going to slow down the nodal tissue, right, and thus decrease the amount of action potentials that are shot down into the heart, because those nodes, if we'll just draw a heart down here quick. So we have atrium, our ventricles. We have the SA node up here, the AV node here, down into the bundle of His, Purkinje's bundle branches. And the action potential comes through the SA node, through the atriums, into the AV node, down, and then into the myocardium of the ventricles. So these calcium channel blockers are slowing the nodal tissue, and also they're decreasing the slope of this myocyte and decreasing the velocity of the action potential. So they're also decreasing action potential velocity. All right, so they affect both the nodal tissue and the kind of cardiac myocytes themselves. And that, will affect phase 0 of the cardiac myocyte, which, we know is this phase here, and the slope that occurs with this initial depolarization. Now, if we go back over, we see that we had cardiac myocytes we talked about, cardiac nodal tissue we talked about. This third thing here, though, is vascular smooth muscle. So we actually also get smooth muscle relaxation. So if we look at an artery, let's say this is the artery is actually kind of wrapped in all this smooth muscle. And the smooth muscle either relaxes and causes vasodilation, or it can contract and cause vasocontraction. Well, with calcium channel blockers, they affect smooth muscle and can lead to vasodilation of the blood vessels. All right, so things that we can kind of summarize for their activity as a class in general is: 1, they can cause vasodilation through the relaxation of smooth muscles. 2, they can decrease contractility, right? 3, they can decrease heart rate through that nodal tissue. And then 4, they can decrease conduction velocity. All right. Now, all calcium channel blockers are not created equal. All right, and that's what we'll kind of discuss at the end here. So we have 2 different kinds of calcium channel blockers. We have, just like beta blockers, cardioselective, and we have non-cardioselective. All right? And when we talk about these two different kind of subclasses of calcium channel blockers, they have somewhat different functionality and then different applications as well. So these cardioselective beta blockers are also termed non-dihydropyridines, which then you can imagine non-cardioselective beta blockers are known as dihydropyridines, which is nice and confusing. So the nons and the dihydros are opposite. So cardioselective is non-dihydropyridine, whereas non-cardioselective is dihydropyridine. I don't know if that's helpful. That helped me remember back when I was in medical school, that non goes with, not non, they're opposites in terms of their titles. The cardioselective non-dihydropyridines are verapamil and diltiazem. And as cardioselective, they're great anti-anginals. So they're great for patients with angina, which is you get chest pain from not enough blood flow from stenosis of the coronary arteries and little clots. But with that being said, they can cause, which makes sense, things like bradycardia, right? Because they slow the nodal tissue down. AV nodal blocks, right? By really inhibiting and slowing down those nodes, and depressed contractility of the heart, which can be really bad in someone with, like, let's say, decompensated heart failure. So you need to be really careful because they have a, tough adverse effect profile that you need to monitor for. Non-cardioselective beta blockers, also known as dihydropyridines, are things like amlodipine, common name is Norvasc, felodipine, isradipine, which can be put down an NG tube, nicardipine, and then nifedipine, also known as Procardia. These are all dihydropyridines or non-cardioselective, also nimodipine and nitrendipine, but I didn't include those. As such, these are often used for things like hypertension. So they're great antihypertensives. Their side effect profile is different from the side effect profile of non-dihydropyridines. Primarily, you'll get things like flushing, headache, swelling in the legs or edema. That's a big one. Someone comes in with bilateral low extremity edema. You can get tachycardia, and obviously hypotension or low blood pressure. All right. One thing I should include over here that I failed to mention is, in addition to anti-anginals, they're often used for kind of atrial tachycardias, AFib, aflutter. All right, so like fib and flutter. So those are class 4 calcium channel blockers. I hope that is helpful. Let us know what thoughts, comments, questions you have down below. Feel free to subscribe and follow along if you feel inclined. Check out some of our other antiarrhythmic videos. Let us know what you think. Stay well, and we'll see you all next time.